Now we are going to discuss congenital abnormalities of kidney and ureter. And in congenital abnormalities of kidney and ureter, first we are going to discuss polycystic kidney disease. So we are going to discuss polycystic kidney disease. Okay. This polycystic kidney disease is further divided into adult onset polycystic kidney disease and infantile polycystic kidney disease. So it is of two types: adult onset polycystic kidney disease and infantile polycystic kidney disease. Okay. Adult onset polycystic kidney disease is also known as autosomal dominant polycystic kidney disease. So this is what? Autosomal dominant. And infantile polycystic kidney disease is autosomal recessive. Clear? So this one is autosomal dominant and infantile polycystic kidney disease is autosomal recessive. Right? One by one we are going to discuss. First we are going to discuss what? Autosomal dominant polycystic kidney disease, also known as adult onset polycystic kidney disease. Right? What are the two chromosomes responsible for this? So the two chromosomes responsible are 16 and 4. In NEET, this question was asked that what is the abnormal protein associated with autosomal dominant polycystic kidney disease? So the name of abnormal protein is polycystin. So the name of abnormal protein is polycystin and the chromosomes associated are 16 and 4. Now see, what is the problem in autosomal dominant polycystic kidney disease? In this case, bilateral kidneys means both kidneys are affected, and in both kidneys, what? There is presence of multiple cysts. Can you see? So both kidneys are replaced by multiple cysts. What is the problem? These cysts are going to compress the vessels, and if there is compression of vessels, there is activation of which system? Renin angiotensin system, and that's why majority of patients will be having what? Hypertension. One problem. What is the second problem? These cysts are going to compress the pelvic calyceal system, and because of compression of pelvic calyceal system, what is the problem? There is stone, increased risk of formation of stone. There is increased risk of infection and hydronephrosis. Second problem. Third problem, slowly you will notice that kidney starts losing its function. So when the function of kidney is going to be lost over a period of time, what is the function? Concentration of urine. So what you are going to notice, that patient is going to pass large volume of diluted urine, the urine which is having low specific gravity. So this patient will be having oliguria or polyuria? Polyuria. So what are the three main problems here? See, first, there is compression of vessels, and because of compression of vessels, there is activation of renin angiotensin system, and because of this, patient will be having hypertension, and the hypertension will be seen in 75% of adults and in 25% of children. Clear? So what is the most common presentation? The most common presentation is hypertension. The most common presentation of autosomal dominant polycystic kidney disease is hypertension. Clear? So this is most common presentation. Okay, first. Second problem, since kidney is replaced by multiple cysts, what is the problem? There is compression of pelvic calyceal system, and because of this compression of pelvic calyceal system, what is the problem? The patients will be having hiss. We discussed in obstruction there is hiss. So what is the full form of hiss? There is stone, there is infection, and there is hydronephrosis. Clear? This stone and infection, this can lead to what? Hematuria. So this can lead to hematuria. Okay. Third problem, since kidney is being replaced by multiple cysts, so third problem, what? Kidney loses the function of concentration. So decreased concentration, kidney loses the function of concentration, and because of this, what's the problem? There is polyuria, and this patient will be having decreased specific gravity of urine. Clear? So what are the presentation? Most common presentation is hypertension, seen in 75% of adults, 25% of children. Other symptoms are these patients are having stone or nephrolithiasis, and that can lead to what? Hematuria. There is polyuria, and this polyuria can lead to nocturia, means in night patient wakes up just for passing urine. So these are the manifestations. Now, what is the most common cause of death in these patients? See the problem. These patients have barrier aneurysm. These patients have hypertension. So, if patient is going to die, generally in majority of cases, it is either because of rupture of barrier aneurysm, or because of coronary artery disease, or because of some complication related to hypertension. So, directly or indirectly, the most common cause of death is what? Cardiovascular disorders. Clear? So, what's the most common cause of death? The most common cause of death. Be careful, initially it was CRF, but nowadays it is cardiovascular disorders. So this is cardiovascular disorders. Okay, this is one problem. Suppose patient is going to survive by 5th or 6th decade. So patient is going to survive for 50 years, 60 years. Slowly and slowly the function of kidney is lost. So what will happen? By 5th to 6th decade, patient is going to develop chronic renal failure. Right? And if patient is going to develop chronic renal failure, how we are going to manage this patient? We have to go for hemodialysis. And what is the treatment of choice for chronic renal failure? Renal transplantation. Right? So by 5th to 6th decade, generally by 5th to 6th decade, these patients are going to develop chronic renal failure. And how we are going to manage chronic renal failure? We have option of hemodialysis and we have renal transplantation. Renal transplantation. Clear? Which one is treatment of choice for chronic renal failure? It's the renal transplantation, right? In many exams, this question is asked. This is asked in radio, medicine, surgery. Okay? One of the very commonly asked questions related to ADPKD is what? What are the extra-renal associations or manifestations? So what are the extra-renal manifestations? This is very, very important. Extra-renal manifestations. Clear? So the most common extra-renal manifestation is what? Polycystic liver disease. So this is polycystic liver disease. This is the most common extra-renal manifestation. Okay. What are the other manifestations? These patients have what? Cyst in ovary, in pancreas, in spleen. These patients have mitral valve prolapse. There is association of barrier aneurysm as we discussed. Clear? There is colonic diverticulosis. Colonic diverticulosis. We can find cyst in seminal vesicle also, and in arachnoid also there is cyst. So cyst in seminal vesicle, cyst in seminal vesicle, and there is arachnoid cyst. In how many cases there is presence of arachnoid cyst? In 8% cases, right? So the most common extra-renal manifestation is what? Polycystic liver disease. Now see one trending question and the controversial question. The question is asked that cysts are not seen in which of the organ? And see the option. In which of the following organ cyst is not seen? First is lungs and second is brain. So it's the lungs in which cysts are not seen. Can you see? Arachnoid cysts are there. In 8% cases, you can see the arachnoid cyst. It means In brain you can find the cyst, but in lungs cysts are not seen. In Bailey it's wrongly written that cysts are seen in lungs. Clear? In Campbell Campbell says that cysts are rarely seen or not seen in lungs. So what is the answer? Cysts are not seen in lungs. Clear? So in lungs, cysts are not seen. Now how we are going to make the diagnosis of ADPKD? The investigation of choice for diagnosis of ADPKD is CECT. So how we are going to make the diagnosis? Investigation of choice for diagnosis, and that is CECT. Simple. Now lots of questions are asked that suppose we are going for IVP, what kind of appearance is seen on IVP? So if we are going for IVP, on IVP this kind of appearance is seen, and you tell me what is the name of this appearance. Clear? So this is spider and this is the leg, so it is looking like spider leg. Also it looks like what? Bell. So it is bell shape. The other appearances are Swiss cheese appearance or bubble appearance, right? So these are frequently asked questions. First, on IVP there is spider leg appearance. It appears like bell, so it's bell shape. There is bubble appearance or Swiss cheese appearance. Clear? Swiss cheese appearance. So these are the questions which are frequently asked. Now see the IVP and see how it looks like. So here you can see that this is the spider and these are the legs. So this is the spider and these are the legs. So this is known as what? Spider leg appearance. Clear? So this is spider leg appearance, right? Now coming to the management, we discussed that most common cause of death is what? Cardiovascular disorders. And if patient is going to survive by 5th to 6th decade, patient is going to develop CRF. So what will be the treatment of choice for CRF? It is renal transplantation, right? So management, if patient develops CRF, the treatment of choice is what? Renal transplantation. Renal transplantation. Okay. What we saw in this disease pathophysiology, that kidney is replaced by multiple cysts. So initially when surgeons were knowing the pathophysiology that this is cyst which is responsible for most of the symptoms. So if I'm going to perform the de-roofing of cyst, symptoms are going to improve and renal function is going to improve. But what? De-roofing of cyst doesn't improve the renal function. And this de-roofing of cyst in ADPKD is known as which operation? It is known as Rosing's operation. You have heard this term Rosing's where? In acute appendicitis. So Rosing sign is the most specific sign for acute appendicitis, and we discussed that what is Rosing sign? On pressing left iliac fossa, there is pain in right iliac fossa. There is third term related to Rosing's, and that is Rosing syndrome. What is Rosing syndrome? You must be knowing horseshoe kidney disease. In horseshoe kidney, the kidney is fused at lower pole. It's like this. So whenever the person is performing hyperextension of spine, there is pressure on the isthmus, and because of this, patient is having what? Abdominal pain, nausea and vomiting. So this is the constellation of symptoms. So this is known as Rosing's syndrome. So three terms which are frequently asked in exam. First is Rosing's operation. So what is this Rosing's operation? It is the de-roofing of cyst. De-roofing of cyst in ADPKD, autosomal dominant polycystic kidney disease. Clear? Second is Rosing sign. And what is this Rosing sign? It's the pain in right iliac fossa on pressing left iliac fossa. Okay. And what is Rosing's syndrome? Rosing's syndrome. Clear? In this case, in patients of horseshoe kidney, which condition? horseshoe kidney, on hyperextension of spine. Hyperextension of spine. What happens? The patients are going to develop nausea, vomiting, abdominal pain. So these patients are going to develop abdominal pain. There is nausea and vomiting. So this was autosomal dominant polycystic kidney disease. Now let's see infantile polycystic kidney disease. Now see, what are the differences? Autosomal dominant polycystic kidney disease was obviously autosomal dominant, but infantile polycystic kidney disease is autosomal recessive. This is also bilateral and means both kidneys are having cyst. But the problem, infantile polycystic kidney disease is very severe. It's very severe form of polycystic kidney disease, and it is so severe that most of the patients are going to die within 2 months of birth. And what is the cause of death? Either the patient is going to die because of pulmonary hypoplasia or because of uremia. Okay. So see, infantile polycystic kidney disease. So first question, this is autosomal recessive. So we discussed it is bilateral. It is most severe form of polycystic kidney disease, and here patients die within 2 months of birth. And generally, what's the cause of death? Here it is because of pulmonary hypoplasia and uremia. Now see, this infantile polycystic kidney disease, it is associated with pulmonary fibrosis as well as hepatic fibrosis. So these are the associations, pulmonary fibrosis and hepatic fibrosis. How we are going to make the diagnosis? Here the diagnosis is made on IVP, and there is a characteristic appearance that's known as sunburst pattern. So how we make the diagnosis? On IVP. And what kind of appearance? There is sunburst pattern. Clear? Problem, we don't have any curative treatment for infantile polycystic kidney disease, so we just go for palliation, means the treatment depends on the complication. So how we are going to manage? There is no curative treatment, so there is no cure, only palliation is done, means the treatment is based on the complication. Another important topic is renal agenesis, and generally incidence is asked that what is the incidence of unilateral renal agenesis. So this is 1 in 1000 live births. So the topic is renal agenesis. And the frequently asked question, what is the incidence of unilateral renal agenesis? And that's 1 in 1000 live births. Clear? Generally it is unilateral renal agenesis, so more common on left side, and generally it is more common in males. Clear? We discussed that whenever a patient is having GI abnormality, congenital abnormalities involving GIT, so the mother will be having polyhydramnios, and whenever the child is having congenital abnormality of genitourinary tract, there is association with oligohydramnios. So what are the associations in this case? It is associated with, or associations. First, these patients have oligohydramnios, right? There is pulmonary hypoplasia, there is amnion nodosum, and in bilateral renal agenesis there is characteristic facies which is known as Potter's facies, and it is associated with bilateral renal agenesis. So what's that? That's Potter's facies. And you have to note down that this is associated with bilateral renal agenesis. Clear? So this is renal agenesis. These are the important points asked in exam. Long back in All India, one question was asked that what is the most common renal vascular abnormality? It is supernumerary renal artery or supernumerary renal vein. What do you mean by supernumerary? Supernumerary means multiple extra. Clear? So question, what is the most common renal vascular abnormality? And it is supernumerary renal artery. So this is another topic. Renal vascular abnormality. Clear? So what is the most common renal vascular abnormality? And this is supernumerary renal artery. It's the supernumerary renal artery. Supernumerary renal vein is also seen, but supernumerary renal vein is less common. Next topic is medullary sponge kidney. So it is medullary sponge kidney. Okay, and it is very easy to remember. So first important point, that this condition is autosomal recessive, right? Now it's very easy to remember how. See, which part of nephron is exclusively located in medulla? So which part of nephron is exclusively located in medulla? It's the collecting duct, and the collecting duct is dilated so that on cut section it is looking like sponge. So what's the problem? Collecting duct, this is dilated. So collecting duct is dilated, it is exclusively located in medulla, and whenever we are taking the cut section, it looks like this. So what? It looks like sponge, and that's why this is known as what? Medullary sponge kidney. Clear? So here, collecting duct is dilated, it is associated with multiple cyst. Clear? And this appearance is known as honeycomb. It's honeycomb appearance or sponge-like appearance. So this is sponge-like. Now what is the problem? In this case, there is presence of multiple cyst, collecting duct is dilated. So there are two problems. One, these patients have infections and these patients have stones. So stones and infections are responsible for most of the symptoms in medullary sponge kidney. What are the associations? So it is associated with hypertrophy, hemihypertrophy. It is associated with hypercalcemia. And you know, this hypercalcemia is a risk factor for stone formation. So if there is stone formation, these patients will be having nephrolithiasis, and there is deposition of calcium in the renal parenchyma, and that's known as nephrocalcinosis. Clear? So because of hypercalcemia, these patients have what? Nephrolithiasis, and these patients have nephrocalcinosis. Okay, so what's the difference? You know that in nephrolithiasis there is formation of stone in the kidney, and what happens in nephrocalcinosis? There is deposition of calcium in the renal parenchyma. Clear? So this is nephrocalcinosis. So we discussed there is stone and there is infection. These are responsible for most of the symptoms. So clinical features, there is stone and infection. These are responsible for most of the symptoms. So what is most common symptom? Because of stone, these patients have renal colic. Okay, these patients have UTI and there is gross hematuria. Clear? So what is the most common manifestation? It's the renal colic followed by UTI followed by gross hematuria. Now what is the investigation of choice for diagnosis? It is IVP, and on IVP typical or characteristic appearance is seen. So see how we are going to make the diagnosis. Investigation of choice for diagnosis, and that's IVP. Clear? Now see what's the typical appearance. If you see, this is the kidney, these are the calyces, minor calyces, this is the major calyx. Now what is the problem? If you see this calyx here, this kind of appearance is there. Can you see? So it is looking like what? Bristles of brush appearance, and it is also looking like what? Bouquet of flowers appearance. So in this picture you can see, can you see? These are the bristles of brush. Can you see? And if you see the whole picture on this side, so this appearance look like what? Bouquet of flowers. So this is very, very important. You will not hear these two terms again. This is bristles of brush and also known as bouquet of flowers. Bouquet of flowers appearance. Okay, so bristles of brush and bouquet of flowers appearance. What is the problem with medullary sponge kidney? That we do not have any curative treatment option. So there is no curative treatment. So here also palliative treatment is done. It means the treatment depends on the complication. So how we are going to manage? There is no cure. Clear? Treatment depends on complications. It depends on complications. Now see, what is the name of this condition? This condition is asked in pediatrics as well as surgery. So the name of this condition is what? PUJ obstruction. This is PUJ obstruction. What is the full form of PUJ? Pelvi-ureteric junction obstruction. Okay, it's very easy to understand. See, this is pelvis, right? And this is what? Ureter. The junction of pelvis and ureter is known as pelvi-ureteric junction. And here you can see it is obstructed. So there is obstruction of pelvi-ureteric junction. Generally, this pelvi-ureteric junction is more common in boys, and it is generally unilateral. So on which side it is more common? It is more common on left side. So this is more common in boys, unilateral, so more common on left side. Clear? Now see the problem. What you can see here at pelvi-ureteric junction, here you can see that there is stenosis, or sometimes there is atresia. So whenever there is atresia or stenosis, what is the problem? There is obstruction, and because of this obstruction, what will happen? The pelvis will be distended. So can you see here? You can notice that here, see, this pelvis is distended. Because of this obstruction, what is the another change? The patient will be having hydronephrosis. So distended pelvis and hydronephrosis. We discussed that this condition is unilateral. It means the opposite kidney or contralateral kidney is functioning and it's normal. So if opposite kidney is functioning, right, what? Most of the patients are asymptomatic. Clear? But after birth, if you are going to palpate the abdomen, what is the most common presentation? There is asymptomatic palpable intra-abdominal mass. Why? Because of hydronephrosis. So because of this hydronephrosis, there is asymptomatic palpable intra-abdominal mass. Right? So what are the causes of PUJ obstruction? It can be congenital or acquired. In congenital, we discussed it can be because of atresia, because of stenosis. There is a condition known as aberrant left renal artery. Aberrant means abnormal origin or abnormal insertion. So what happens? This is renal artery. There is abnormal left renal artery, and it is going to compress the ureter at pelvi-ureteric junction. So because of this compression, what happens? There is obstruction. These are the congenital causes. Now coming to acquired causes. What is the most common acquired cause of PUJ obstruction? So obviously it's the stone. And what is the other cause? It's the stricture. And what's the cause of stricture? Stricture can occur because of instrumentation or because of infection. Clear? So what are the causes? It is divided into congenital and acquired causes. In congenital causes, there might be atresia or stenosis of ureter at PUJ, and sometimes there is aberrant left renal artery. In acquired causes, we discussed it is because of calculus or because of stone, and it is because of infection or instrumentation. Infection or instrumentation, and this infection and instrumentation, this can lead to what? Strictures. Clear? The good thing is that in majority of cases this is unilateral. So what? Most of the patients are asymptomatic and there is palpable intra-abdominal mass. One important point, can we make the diagnosis of this condition during pregnancy? We can. So how? Mother will be having oligohydramnios or polyhydramnios. So we discussed that the patients who are having congenital abnormalities involving genitourinary tract, the mother is going to have oligohydramnios. Clear? So we can make the diagnosis during pregnancy. Now after birth, most of the patients are asymptomatic. So patient is asymptomatic, and what is the most common presentation? There is palpable intra-abdominal mass. Now how we are going to make the diagnosis? See, when DTPA scan was not there, at that point of time IVP was the investigation of choice. But after invention of this DTPA scan, what? DTPA scan became the investigation of choice. Why? Because in DTPA scan, you know that what is the function of the kidney. So you can know, you can easily assess what is the function of both kidneys. So how we are going to make the diagnosis? Investigation of choice for diagnosis, it's the DTPA scan. Why? Because this DTPA scan tells you about the function also. Function of both kidney, exact function. Now see, sometimes this investigation is equivocal. Suppose it is equivocal, you are not 100% sure whether this patient is having PUJ obstruction or not. In that case, we go for pressure flow studies. So if it is equivocal, so we go for pressure flow study. And what's the name of this pressure flow study? It's very easy to understand. The name of this test is Whitaker's test. Now how we do this Whitaker's test? Imagine this is the kidney, here is the obstruction, this is the ureter, and this is the bladder. Clear? Here is the obstruction. So percutaneously we have to inject the dye into the pelvis. So can you see? Percutaneously you injected the contrast or dye into the pelvis, and after that you are going to measure what? The intra-pelvic pressure. So what is this pressure flow study? So we are going to measure the intra-pelvic pressure. See, if there is obstruction, you will notice that there is rise in intra-pelvic pressure. So after percutaneous injection of contrast in the pelvis, if there is rise in intra-pelvic pressure, it means there is obstruction, and the name of this test is Whitaker's test. So what's the name of this test? This is Whitaker's test. And in this case, percutaneous, what we do? Percutaneous injection of contrast into pelvis, and after that there is rise in intra-pelvic pressure. And if there is rise in intra-pelvic pressure, this is suggestive of PUJ obstruction. Clear? So what is the name of this intervention? This is the gold standard treatment for PUJ obstruction, and this is Anderson-Hines dismembered pyeloplasty, right? So what's the management? The gold standard treatment. This is Anderson-Hines dismembered pyeloplasty. Okay, Now see how we are going to do this dismembered pyeloplasty. See, here is the obstruction. So we have to remove or excise the unhealthy part, and after that we have to perform the anastomosis, right? Now here you can see that there is blue colored thing inside the ureter and pelvis. What is this? This is DJ stent. And you must be knowing, whenever we are going to perform some urological intervention to maintain the patency of ureter, what we have to insert? DJ stent. So this is Anderson-Hines dismembered pyeloplasty. There are certain other questions which are asked related to various treatment options in PUJ obstruction. So see other treatment options. The treatment options are further divided into open treatment and endoscopic treatment. Clear? In open treatment, overall we discussed that what is the gold standard treatment option is the Anderson-Hines dismembered pyeloplasty. Okay, what are the other options? We can go for Foley VY pyeloplasty. So second option, we can go for Foley VY pyeloplasty. We can use flaps also, like spiral or vertical flap. So use of flaps, either spiral or vertical. Now in endoscopic treatment we have two options. One is endopylotomy and second is balloon dilatation. So we have treatment options. One is endopylotomy and the second is balloon dilatation. Okay. In exam this question was asked that in which cases endoscopic treatment is used. So whenever the patient is having small intrarenal pelvis, so if the patient is having small intrarenal pelvis, in those cases we go for endoscopic treatment. So this is for small or intrarenal pelvis. Clear? So this is how we manage PUJ obstruction. Now tell me, what is the name of this condition? In this diagram, what you can see, if you see on right side, what you can see that this is the ureter, and see this ureter takes what? It goes behind IVC, takes U-turn before draining into the bladder. So what? This ureter is entrapped behind IVC and this ureter is embryologically normal. So since it is going behind IVC, it is known as retrocaval ureter. And can you see it is around IVC? So what? It is also known as circumcaval ureter. Now the problem. It gives you perception that here ureter is abnormal, but it's not like that. What? Here the development of IVC is abnormal and the ureter is embryologically normal, and because of IVC abnormality it is entrapped behind IVC. Okay, so what's the name of this condition? This is retrocaval ureter. It was asked many times in NEET and DNB. And what's the other name? It is also known as circumcaval ureter. Clear? Here, embryologically normal ureter, it's entrapped behind IVC. Clear? So this is entrapped behind IVC. Clear? So it is because of abnormality of IVC development, and this was asked in NEET. So in this case there is abnormal persistence of right posterior subcardinal vein. This was the question. So what's the problem? In this case there is abnormal persistence of right posterior subcardinal vein. This was the question. right posterior subcardinal vein. Right now it's very easy to understand the symptoms. So here you can see that since this ureter is going behind IVC and it is entrapped, so what's the problem? There is obstruction. So if there is obstruction, the proximal system or proximal part will be dilated and the distal part will be collapsed. So here you can see this is dilated, this part is dilated, this part is collapsed. And can you see the appearance? Because of this kind of compression or obstruction, what's the problem? These patients will be having signs and symptoms of ureteric obstruction. 1. Investigation of choice for this soft tissue relation is what? MRI. MRI. Suppose we are going for IVP, and if we are going for IVP, what kind of appearance is seen? Here you can see this kind of appearance. So this is what? Reverse J, fish hook or Shepherd crook appearance. Clear? So see the clinical features. These patients have signs and symptoms of ureteric obstruction. Clear? How we make the diagnosis? Diagnosis. Here, investigation of choice for diagnosis. You have to remember this is MRI. And the questions which are asked in exam, what's the name of this appearance? Can you see? This is reverse J, fish hook or Shepherd crook. So on IVP, there is reverse J, fish hook or Shepherd crook appearance. Shepherd crook appearance. Clear? Treatment part is very easy to understand. Since the ureter is going behind IVC and that's why there is obstruction, what you do? See, I'm going to excise this part of ureter which is going behind the IVC. So you excise or divide the ureter, and after dividing ureter, clear? I divide ureter, I'm going to perform the anastomosis. Right? So after dividing it, I'm going to perform the anastomosis. So since I'm locating the ureter to its normal course, this is relocation, doing anastomosis between ureter and ureter. So this is ureterostomy. So what's the name of this treatment? Treatment. This is known as relocation. What's the name? This is relocation. Ureterostomy. Ureterostomy. Clear? So what is the treatment of choice? It's the relocation ureterostomy in cases of retrocaval ureter. Now see this image. Here you notice that the kidney is fused at the lower pole. It's looking like horseshoe. Name of this condition is horseshoe kidney. Okay, what is the incidence of horseshoe kidney? It is 1 in 400 live births. So incidence, it is 1 in 400 live births, and that is 0.25%. Generally, horseshoe kidney is more common in males. See, there is similarity between kidney and testes. What is the similarity? That both of these organs are going to change their permanent position after development. First, let's discuss testes. In testes development occurs from posterior abdominal wall. So testis develops from posterior abdominal wall, but its final destination is in the scrotum. So why? Because in scrotum the temperature is 2 degrees centigrade below the body. So for the effective spermatogenesis, testis goes into scrotum. 1. Second, now see the kidney. Kidney develops from pelvis, and after development from pelvis it is going to ascend up, and after ascent, when it reaches in the renal fossa, what happens? Initially the axis of kidney is vertical, so after ascent it is going to rotate, so axis becomes oblique. Now the problem, whenever kidney is fused at the lower pole and suppose there is ascent, so what is the problem? There is one vessel in the midline arising from aorta. Can you see this vessel? So this is inferior mesenteric artery. So the name of this vessel is inferior mesenteric artery, and its location is lower border of L2. So since it's in midline, it is going to prevent the ascent. And if it is going to prevent the ascent, what will be the level of isthmus in horseshoe kidney? This is L3, L4. The level of inferior mesenteric artery is lower border of L2. So the level of isthmus will be L3, L4, 1. Second, kidney is not able to rotate. So what's the problem? The axis of kidney, axis, it remains vertical. Third problem, in kidney, if you see, generally what is the orientation of calyx? See, this is the kidney. If you see the orientation of calyx, the calyx is generally lateral or posterior. You will not find medial calyx. Why? Because medially there is presence of pelvis. Right? Now see this condition. If you see this particular condition, in this case you will find what? Medial calyx. Can you see? Why there is presence of medial calyx? Because there is isthmus. So near isthmus, can you see? You can see the calyx. Clear? So because of presence of this calyx here, right, this kind of appearance is seen on IVP, and this is known as what? Hand joining sign. One problem. Now second problem, you notice here that in the lower part of or lower pole of kidney is fused. So what will happen? You will notice that the ureter, what is the abnormality? There is high insertion of ureter, and this ureter has to cross the isthmus. So there is high insertion of ureter, and ureter has to cross isthmus. So what? There is anterior transposition of ureter. Because of this anterior transposition of ureter, what's the problem? Certain patients are having signs and symptoms of obstruction. So patients might be having what? Stone, infection and hydronephrosis. And because of this high insertion of ureter with anterior transposition, the characteristic appearance on IVP is known as flower vase like curve of ureter. So these are the problems. So we are going to discuss the important points related. First, inferior mesenteric artery prevents the ascent. Prevents the ascent. Okay. Level of isthmus. Level of isthmus. And that is L3, L4. Okay. What is the axis? Axis of kidney. Axis remains vertical. What is the other problem? There is medial calyx, and because of this presence of medial calyx, which sign on IVP, there is hand joining sign, and because of high insertion of ureter and anterior transposition. So there is high insertion and anterior transposition. What's the problem? There is flower vase like curve. Flower vase like curve of ureter. Clear? And these are the two questions which are most frequently asked. Most frequently asked. Now see, in majority of cases, what is the problem? The part of kidney is located already in the pelvis, bladder is also in the pelvis, so this obstruction is not very prominent. So majority of patients remain asymptomatic. And if patient remain asymptomatic, how we are going to make the diagnosis? It is diagnosed incidentally on radiological investigations. So most of the patients are asymptomatic. It is diagnosed incidentally on radiological investigations, and because of anterior transposition of ureter, obstruction is seen. So certain patients are going to develop what? His means stone, infection and hydronephrosis. So see the presentation. Clinical features. Majority of patients are asymptomatic. Diagnosed incidentally. And if the patient is having symptoms, what is the most common symptom? There is vague, dull aching pain. So what is the most common symptom? Is the vague, dull, aching pain. And we discussed that this patient can have stone infection and hydronephrosis. There is a constellation of symptoms. See, whenever this patient is performing hyperextension of spine, there is pressure on this isthmus, and because of that, there is abdominal pain, nausea, vomiting. What is the name of this condition? It is known as Rosing's syndrome. So this patient is also having Rosing's syndrome. So what's the problem? On hyperextension of spine, these patients might develop abdominal pain, nausea and vomiting. Now the diagnosis. How we are going to make the diagnosis? See, when CT was not discovered, at that point of time we were performing IVP as well as angiography. Why? IVP for the diagnosis of horseshoe kidney and angiography because this is associated with abnormal vascularity. Nowadays we have a single investigation which can tell us about the horseshoe kidney and abnormal vascularity, and that is CT angio. So investigation of choice for diagnosis is CT angio, and in majority of times or in most of the questions CT angio option is not there. And suppose CT angio option is not there, so what other option is there? CCT. So if CT angio is not there, then you have to choose what? CCT. So what is the investigation of choice for diagnosis? It is CT angio, and if CT angio is not given in the option, then you go for CCT. Why? Because we have to diagnose horseshoe kidney, and we have to detect and we have to diagnose that what is the vascular pattern, what abnormal vessels are going to supply the kidney. One, if we are performing IVP, what are the characteristic appearances? So in the first image you can see that there is medial orientation of calyx, and because of that this kind of appearance is seen. This is known as hand joining sign. So because of medial orientation of calyx, this is known as hand joining sign. Okay, and in the second image you can see that there is flower vase like curve of ureter. So this is what? Flower vase like curve. And why there is flower vase like curve of ureter? Because there is high insertion and anterior transposition of ureter. So these are the appearances which are frequently asked in exam. Now coming to the treatment. In horseshoe kidney we are going to manage the complications, and we discussed that what is the problem? There is stone, infection and hydronephrosis. Now imagine there is presence of stone, and this question was asked in NEET, that there is presence of staghorn calculi in horseshoe kidney. What is the treatment option? So we discussed in the stone management that for staghorn calculi we go for sandwich technique, ESWL and PCNL. But the problem, the location of kidney is abnormal here. So here we only go forward PCNL, right? So if there is staghorn calculi in horseshoe kidney, we go for PCNL. Second, whenever we are performing the treatment, this isthmus should not be divided. Why the isthmus should not be divided? Because isthmus contains the functional tissue. Third, in pregnancy, what complication we can expect? So see, since some part of kidney is going to occupy the pelvis, so head of fetus is not going to engage in the pelvis, and because of that there is difficulty in the labor, that's known as dystocia. Okay, so coming to the management options, in this case we go for management of complications. And the question, if there is staghorn calculi, this was asked in NEET. In this case, if there is staghorn calculi, we go for PCNL. Very important point, isthmus should not be divided. Isthmus should not be divided. Why? Because it contains the functional tissue. And the third problem, that in patients, pregnant patients, so in pregnancy, it can lead to difficulty in labor and that's what? Dystocia. Now see this image and tell me what is the diagnosis here. So here you can see that there is cystic dilatation of terminal part of ureter. Okay, so cystic dilatation of terminal part of ureter, and this is known as ureterocele, right? So the name of this condition is ureterocele. Ureterocele. Okay, this is cystic dilatation of terminal part of ureter. This ureterocele is more common in females. What are the types of ureterocele? See, it is of two types. One is intravesical and the second is ectopic. Intravesical means it is inside the bladder. So here you can see that this is within the bladder. So this is intravesical, and second is ectopic. Now see what is the distribution. Intravesical ureterocele is responsible for 20% cases, and ectopic ureterocele, this is responsible for 80% cases. Now what is the meaning of ectopic ureterocele? Generally this ectopic ureterocele is associated with duplication of ureter. What is the meaning? Imagine that this is the bladder, this is the urethra, this is the kidney, this is one ureter, and this is the second ureter. So here you can see this upper pole ureter is having cystic dilatation, and the upper pole ureter is opening into prostatic urethra. Clear? So this is what? Duplication of ureter, because two ureters are there, and upper pole ureter is having ureterocele which is not opening into the bladder. So this is what? Ectopic ureterocele. So overall ectopic ureterocele is more common, and this ectopic ureterocele is associated with what? Duplication of ureter. Now what are the changes which are occurring in ureterocele? Imagine that this is kidney, this is the ureter, this is the bladder. Okay, now here is the ureter, and this ureter is having ureterocele. Because of this ureterocele, what happens? There is relative outflow obstruction to the urine. So because of this relative outflow obstruction, what happens? There are back pressure changes. So because of these back pressure changes, what happens? There is hydroureteronephrosis. So this patient will be having what? Hydroureteronephrosis. Okay, one. Second, we discussed that one of the biggest defense mechanism in biliary tract and in the urinary tract for the infection is flow. Okay, so if there is any obstruction to the urine flow or to the flow of bile, what happens? There is increased risk of infections. So since here there is obstruction to the urine flow, so what's the problem? This patient is having increased risk of infection. So these patients are having increased risk of infection. There is hydroureteronephrosis, and because of this hydroureteronephrosis, if you palpate abdomen, there is what? Palpable. So there is palpable intra-abdominal mass. Clear? So these are the presentations. So what are the presentations? Clinical features. These patients have recurrent UTI or urosepsis. Recurrent UTI or urosepsis. There is hydroureteronephrosis, and that leads to palpable intra-abdominal mass. Now how we are going to make the diagnosis? Suppose we are going for ultrasound. If we are going for ultrasound, obviously we are going to detect what? Hydroureteronephrosis. Simultaneously there is presence of what? Ureterocele in the bladder. So you will find a cyst. Okay, if you go for IVP, this kind of appearance is there. This is known as adder head or cobra head appearance. Whenever we are going for MCU, micturating cystourethrogram, we are going to find a filling defect at the site of ureterocele. And if we are performing cystoscopy, what we can see? We can see that urine comes in this ureterocele and then it goes into the bladder. So what we can see on cystoscopy? Enlarging and collapsing cyst. So these are the findings. So if we go for ultrasound, on ultrasound there is hydroureteronephrosis with cyst in the bladder. Okay, on IVP, this is the characteristic appearance. So here you can notice that here it's bilateral ureterocele You can notice that bilateral adder head or cobra head appearance. Simultaneously, what else you can see? You can see that because of back pressure changes, there is hydroureteronephrosis. So on IVP, there is adder head or cobra head appearance. So there is adder head or cobra head appearance. Clear? If we go for MCU, micturating cystourethrogram, so on MCU, what we are going to find, there is filling defect. Filling defect. Clear? And we found what on cystoscopy? On cystoscopy, there is enlarging and collapsing cyst. Enlarging and collapsing cyst. Now see, the treatment depends on the type of ureterocele. Imagine this patient is having intravesical ureterocele. So if the patient is having intravesical ureterocele, what we are going to do, we are giving incision over the cyst wall, and what it is going to open into the bladder. So whatever the outflow obstruction was there, it is relieved. Okay, so if it is intravesical, we give incision over the cyst wall. Now imagine a second situation. If a patient is having ectopic ureterocele, in ectopic ureterocele, what we have to do, we have to excise. So we have to perform what? Excision. So we have to excise it, and after excision, what we have to perform? Reimplantation into the bladder. So for ectopic ureterocele, the treatment is excision with reimplantation into the bladder. So see the treatment for intravesical ureterocele. We go for incision over the cyst wall. Incision over the cyst wall. Okay, and for ectopic ureterocele, you saw, for ectopic ureterocele, we go for excision with reimplantation. Excision with reimplantation. Clear? So this is how we manage the ureterocele. Now two important questions are asked related to congenital abnormality of upper urinary tract and urogenital tract. Now see, first important point. What is the most common congenital abnormality of upper urinary tract? Then the answer is duplication of ureter. And if the question asked what is the most common congenital abnormality of urogenital tract, in that case it is the VUR. So two important questions. First, most common congenital abnormality of first upper urinary tract and the second is urogenital tract. Urogenital tract. Okay, so in upper urinary tract, most common congenital abnormality is duplication of ureter. This is duplication of ureter. Okay, and in urogenital tract, it is VUR, vesico-ureteric reflux. So what is the similarity between duplication of ureter and VUR? That both of these are autosomal dominant. These are autosomal dominant. Okay, so one by one we are going to discuss. First we are going to discuss duplication of ureter. Duplication of ureter. So this is the most common congenital abnormality of upper urinary tract, and this is more common in females. This is bilateral. Now see how it looks like. So if you see this image, this is the normal finding, and here you can see that there is duplication of ureter. In the second one, there are two ureters on each side. right? Now if you see on the right side, you will notice that what, there are two ureters, but these two ureters are going to join together, and then these are going to enter into the bladder. It means what kind of duplication is this? This is incomplete duplication, and this incomplete duplication is also known as bifid ureter. And if you see the second one, in this case you will notice that this yellow colored upper pole ureter, this is going to enter into the urethra, and if you see this orange colored lower pole ureter, this is going to enter into the bladder. So here you are going to see two separate ureters with two different openings. So what kind of duplication is this? This is complete duplication. So see what are the types. So there are two types. First, this is incomplete duplication, and this is complete duplication. Incomplete duplication is also known as bifid ureter. So here you can see bifid ureter. Now imagine if I'm going to perform one investigation, and the name of investigation is RGP, what? Retrograde pyelogram. So if I'm going to perform retrograde pyelogram, can you see the contrast goes like this, it goes like this, and then it enters into this limb and then enters into this limb. So what happens? You notice that there is reflux of contrast in both limbs of ureter, and this reflux on RGP is known as yo-yo reflux. So what's the name? In bifid ureter there is yo-yo reflux. On which investigation? On RGP. So what is this yo-yo reflux? Reflux of contrast in both limbs of ureter. Now coming to this complete duplication. Okay. Now here you can see that this upper pole ureter, yes, which is opening into prostatic urethra, and you can see this is the lower pole ureter, orange color. So if you see the upper pole ureter, this upper pole ureter is caudal means distal, and medial to the lower pole ureter. See, this is the midline. So if you see, this upper pole ureter is closer to the midline as compared to the lower pole ureter. So what you saw in this picture, upper pole ureter is distal or caudal and medial to the lower pole ureter. And what is the name of this law or rule? This is known as Wiegert-Meyer's rule, and this was asked in NEET. So the name of this rule, this is Wiegert-Meyer's rule. So what is this Wiegert-Meyer's rule? The upper pole ureter is caudal and medial to the lower pole ureter. One problem. Now see the second problem. Here two ureters are there in complete duplication. Now if you see this upper pole ureter, this upper pole ureter is having ureterocele. So what's the problem? This upper pole ureter is having ureterocele. And if you see the lower pole ureter, it is having short intravesical length, and because of short intravesical length, the lower pole ureter is having what? VUR. Lower pole ureter is having VUR. Okay, one problem. Second problem, if you see the upper pole ureter which is having ectopic ureteric orifice, in males the most common site of insertion is prostatic urethra, and in females what is the most common site? It is anterior urethra. So it's very easy to understand. Imagine that this is a male patient, this is the kidney, this red colored upper pole ureter, it's opening into prostatic urethra, and this green colored lower pole ureter opening into bladder. Now this is a female patient. In this female patient, this is the kidney. Here you can see this upper pole ureter opening into anterior urethra, and this lower pole ureter, this is opening into bladder. Okay, now what is the catch? In males, if you see, this opening is proximal to external urinary sphincter, whereas in females this opening is distal to external urinary sphincter. So in males, if the opening of ectopic ureter is proximal to external urinary sphincter, it means there is no incontinence in males. But what is the problem? In females, you will notice that there is incontinence. And what kind of incontinence? There is continuous incontinence. Female patients will come to you and say that, sir, there is continuous dribbling of urine. Simultaneously, they will give you the history of normal voiding pattern. They will tell you that, sir, when my bladder is full, I go and pass urine. But simultaneously, there is continuous dribbling of urine. Okay, so important point. What is the most common site of ectopic ureteric orifice? Ectopic ureteric orifice. So you saw in males, it is prostatic urethra, and in females it is anterior urethra. In females it is anterior urethra. That's why in males, what is the feature finding? Clinical features, these patients are having recurrent infections. So these patients have recurrent infections. Clear? And what's the problem in females? These females have continuous incontinence. Continuous incontinence. Clear? With normal voiding pattern. Normal voiding pattern. Okay, so the females will complain of continuous dribbling of urine. Clear? This is the clinical features, list of clinical features. Now see, in this patient there are two problems. What problems you saw? That this lower pole ureter, this is upper pole ureter. This upper pole ureter is having ureterocele, and this lower pole ureter is having VUR. Clear? So this patient is having two problems. It means there will be two investigation of choices and there will be two types of treatment. So if we are talking about the upper pole ureter which is having ureterocele, what is the investigation of choice? It's the IVP. And on IVP, what is the appearance? Adder head or cobra head appearance we discussed. So on IVP there is adder head or cobra head appearance. Clear? For vesicoureteric reflux, VUR, what is the investigation of choice? So here the investigation of choice will be MCU. Clear? Diagnosis is done, and now we have to perform the treatment. Now for lower pole ureter which is having VUR, for this VUR, what we are going to do, see, this is the bladder, this is the lower pole ureter. So we have to strengthen this junction. What is the name of this junction? This is uretrovesical junction. And if you strengthen this uretrovesical junction, this surgery is known as uretrovesicoplasty. So what's the management? For lower pole ureter which is having VUR, for lower pole ureter which is having VUR, clear? We go for uretrovesicoplasty. Uretrovesicoplasty. Okay. For upper pole ureter which is having ureterocele, now see what we do here. This is the bladder. Here is the upper pole ureter. So what we do, we are going to excise this upper pole ureter, and after excision of this upper pole ureter, what we do, we perform reimplantation into the bladder. So for upper pole ureter, we perform excision with reimplantation. Excision with reimplantation into bladder. Reimplantation into bladder. Simple. Now the problem. Sometimes in advanced cases because of back pressure changes. Why? Because of obstruction caused by ureterocele. The patient is having hydronephrosis and the function of upper pole is almost lost. And whenever the function of upper pole is almost lost and we are going to perform IVP, what kind of appearance is seen? Now see, in this patient is having upper pole hydronephrosis. That's why upper pole function is lost, and this upper pole hydronephrosis is going to cause what? Depression of this lower pole. So the lower pole appears drooped down, and whenever you are going to perform what? IVP, this kind of appearance is seen. So in this case you can compare. What's the name of this appearance? This is known as drooping lily sign. This was asked many times in exam. This is drooping lily sign, and this drooping lily sign is not only seen in duplication of ureter, this is also seen in which case? Neuroblastoma. So duplication of ureter in which there is ectopic ureteric orifice, what happens? There is drooping lily sign, and whenever there is neuroblastoma, the tumor is also going to displace kidney inferolaterally, and because of that what? This sign is seen. So this is known as drooping lily sign, and it is seen in both ectopic ureteric orifice, patient which is having duplication of ureter, especially upper pole, and neuroblastoma. Clear? And since there is no function, whenever duplication of ureter is there, when there is no function in the upper pole, in this case what's the management? We go for upper pole nephrectomy. So we go for upper pole nephrectomy. So this is how we manage the patients of duplication of ureter. Now we are going to discuss vesico-ureteric reflux. Okay, we discussed that this is autosomal dominant. Vesico-ureteric reflux is the most common congenital abnormality of urogenital tract, and this is more common in children. Majority of patients are asymptomatic. Why? Because it's low grade in majority, and since it's low grade in majority, it resolves spontaneously. In most of the patients. Okay, now see, it's very easy to understand the logic behind VUR. You can see this is bladder, this is prostate, this is urethra, here this is trigone, this is the uretrovesical junction. Now how the bladder, trigone and uretrovesical junction, yes, all these are going to participate in prevention of vesico-ureteric reflux. See, in the bladder there is oblique insertion of ureter like this, and there should be adequate length of ureter inside the bladder, so that whenever the bladder is going to compress or contract, there is closure of this uretrovesical junction, there is no VUR. Imagine if the patient is having short intravesical length, in that case there is inadequate closure, and because of this there will be VUR. Second, over the surface of ureter there is presence of longitudinal muscles which helps in the closure. So if there is deficiency of these longitudinal muscles, there is inadequate closure and there is VUR. These are the primary causes of VUR. Now what's the secondary cause? Imagine that the patient is having posterior urethral valve. If this patient is having posterior urethral valve, what will happen? Bladder will be distended, and over a period of time when the urine comes, it will be distended further. So when bladder is stretched, because of this stretching of bladder, what happens? This uretrovesical junction is also stretched. So this uretrovesical junction is also stretched, and if it is stretched, what happens? Because of distension, there is reflux of urine. Similar situation occurs in adults who are having neurogenic bladder, in which bladder is stretched, distended with urine. So how to understand? It's very easy to understand this theory. Imagine that you are going to puncture a balloon in deflated state. Okay, and after puncturing the balloon with a pin in deflated state, try to inflate the balloon. More you inflate the balloon, that site of puncture starts increasing its size. So the same thing happens to the bladder. When it's distended, uretrovesical junction is stretched and there is reflux. So this is secondary cause of VUR. So see the causes. First, primary cause, and then secondary cause. Okay, so what are the primary causes? First, short intravesical length, of ureter, and deficiency of longitudinal muscles over surface of ureter. Secondary causes: in children it is posterior urethral valve, and in adults it is neurogenic bladder. Clear? So these are the causes. Now coming to the diagnosis. Investigation of choice for diagnosis of VUR, you must be knowing, is MCU. So what is the investigation of choice for diagnosis? It's MCU. What is the full form of MCU? It's the micturating cystourethrogram. See how we perform MCU. We have to inject the dye into the bladder and we ask the patient to pass urine and we take serial X-ray. Now see, when patient is passing urine, patient is going to contract the bladder, and after contracting the bladder, the dye is there in the bladder and that dye comes out via urethra. It means by this micturating cystourethrogram, you are not only evaluating the bladder, you are evaluating the urethra also. Obviously, which part? Posterior part. So whenever patient is going to contract the bladder, and if there is reflux of dye into ureter, it means there is vesico-ureteric reflux. And if there is some kind of obstruction in posterior urethra, you can diagnose that. So in children, if there is urethral valve, posterior urethral valve, you can diagnose. In adults, if there is stricture in posterior urethra, you can diagnose. It means MCU is investigation of choice for three conditions. First, VUR. Second, posterior urethral valve, and third, posterior urethral stricture. There is a classification system of VUR based on MCU, and the name of this classification system is International Classification of VUR. So this is International Classification of VUR based on MCU. It's very easy to understand. There are 5 grades. Okay, now see what happens in grade 1. The blue color is the contrast. So here you can see that in grade 1 there is contrast. So there is reflux of contrast where into the ureter. So you can see what, that there is reflux of contrast into the ureter, but ureter is non-dilated. So what is grade 1? There is reflux of contrast in non-dilated ureter. Okay, now see grade 2, grade 3, grade 4, grade 5. There is one similarity, that in all these 4, grade 2, 3, 4, 5, in all these there is reflux of contrast till pelvic calyceal system. Can you see? Pelvic calyceal system. So in rest all there is reflux of contrast into pelvic calyceal system. This is the similarity. Okay, now see the differences. In grade 2 there is non-dilated ureter. So here you can see there is non-dilated ureter. So what is grade 2? Reflux of contrast into pelvic calyceal system, right? So there is with non-dilated ureter. Now what happens in grade 3? There is mild to moderate dilatation. So reflux of contrast into pelvic calyceal system with mild to moderate dilatation of ureter. Now see the grade 4, the characteristic finding. If you see this part, this is known as fornix. And what you are going to notice here, that there is blunting of fornix. This becomes flat. So what is this? This is blunting of fornix. So in grade 4, there is reflux into pelvic calyceal system with blunting. With blunting of fornix or fornices. And what happens in grade 5? Reflux into pelvic calyceal system, but You can see the ureter, it is dilated and tortuous. So reflux of contrast into pelvic calyceal system with dilated and tortuous ureter. So this is dilated and tortuous ureter. Clear? What is good thing about this VUR? That by 5 to 6 years of age, when bladder matures completely, low grade VUR disappears. So what are the chances of spontaneous resolution in various grades of VUR? Okay, so see, in grade 1 and 2, it is 80%. In grade 3, it is 50%. In grade 4, it is 20%, and in grade 5, it's 0 to 5%. So these are the chances of spontaneous resolution. In majority of cases, there is low grade VUR. So generally what is recommended? Only observation. Now imagine a patient is having low grade VUR and only observation is being done. Right now, unfortunately, this patient developed UTI, urinary tract infection, and since patient is having UTI, because of this vesico-ureteric reflux, the infection can reach up to the kidney. So if patient is going to develop UTI, this infection can reach to the kidney, and now this UTI can be converted into pyelonephritis. Acute pyelonephritis can be converted into chronic pyelonephritis, and because of this chronic pyelonephritis, patient might develop permanent changes in the kidney like scar. And if patient develops permanent changes in the kidney like scar, this can lead to hypertension. Clear? So you don't want the permanent change in the kidney, you don't want scar, so you don't want pyelonephritis, and if you don't want pyelonephritis, you don't want UTI, and if you don't want UTI, what patient needs? Antibiotics. So that's why irrespective of grade of VUR, all patients are recommended what? Antibiotics. So we have to give antibiotics. So antibiotics are given to all the patients. Imagine if the age of patient is up to 6 weeks. So in these patients we give ampicillin or amoxicillin. Clear? So ampicillin or amoxicillin, and if the patient age is more than 6 weeks, in this case we give trimethoprim sulfamethoxazole. Then question is asked that in which grades medical management is sufficient. So medical management is sufficient in grade 1 to grade 3 VUR and unilateral grade 4 VUR, right? So medical management, it is sufficient for grade 1 to grade 3 VUR and unilateral grade 4 VUR, right? So there is a common sense question. What are the indications of surgical intervention? So obviously what? Bilateral grade 4 VUR and grade 5 VUR. So the indications for surgical intervention. Indications for surgical intervention. So the common sense indications: first, bilateral grade 4 VUR. Second is grade 5 VUR. Apart from these, if a patient is having recurrent UTI or recurrent infection despite of antibiotics, if a patient is old enough, means beyond 5 to 6 years of age, because chances of spontaneous resolution are lesser, and if patient is having permanent changes in the kidney or patient is having bladder diverticula, in all these cases surgical intervention is recommended. So third, recurrent UTI despite of antibiotics, older children, permanent changes in the kidney or permanent scar, and bladder diverticula. diverticular. Clear? So in all these cases, surgical intervention is recommended. Now, simple question, what kind of surgical intervention? So it's very easy to understand. See, this is bladder, this is prostate, this is urethra. Now imagine that this is the uretrovesical junction. Okay, what we do, we are going to strengthen this uretrovesical junction, and this strengthening is known as uretrovesicoplasty. One. Second, sometimes we are going to inject the Teflon injection around this. So what? Subureteric transurethral injection of Teflon, and this is known as sting operation. So what are the options? First, uretrovesicoplasty. Second is sting operation. Okay, and in sting operation, what we do, S means subureteric, T means transurethral, I means injection of Teflon paste. So in sting, STI is taken. Okay, so if it's possible to repair, we are going to perform the repair, and if it's not possible to repair, then we perform the ureteric reimplantation. So what is the third option? We go for ureteric reimplantation. Okay, and what are the methods of ureteric reimplantation? One is known as Litch-Grigor technique, and second is Leadbetter-Politano technique. So Litch-Grigor technique, and second is Leadbetter-Politano technique. Leadbetter-Politano. Clear? So there is Leadbetter-Politano technique. This question was asked in DNB that out of these two, which one is preferred? We prefer Litch-Grigor technique. Clear? So these are the treatment options for VUR. So this is all about kidney and ureter.